Today we are going to talk about pre-diabetes 2025 update. Pre-diabetes is a toxic cardiometabolic state associated with increased microvascular and macrovascular complications. 33.6% of outpatients had prediabetes based on hemoglobin A1C results. We are going to talk about how reliable hemoglobin A1C is in diagnosing diabetes and also prediabetes. The most important thing is only less than 1% were recognized as prediabetes by the clinicians. Out of that 1%, only 23% had documented treatment, either lifestyle modification and or with metformin, meaning only 0.25% gets or got any treatment based on the article published on Diabetes and Endocrinology 2015. This is from United States. Prediabetes or intermediate stage of glucose dysregulations as said by World Health Organization. It precedes type 2 diabetes. It affects 720 million people worldwide. It will be 1 billion by 2045. In the United States, approximately 10% of the people with prediabetes progress to diabetes each year. This is a statistics from American Diabetic Association. 97.6 million Americans have prediabetes. That is 1 in 3, which is high number. When the age is 65 plus, the incidence is 50%. That means half of them have prediabetes. There are 3 organizations who have come up with slightly different diagnostic criteria. We go with American Diabetic Association because it is the latest, 2023. They use fasting glucose level, impaired glucose tolerance, which is 2-hour postprandial glucose, and hemoglobin A1C. Hemoglobin A1C may be an unreliable marker under certain conditions like hemolytic anemia, iron deficiency, hemoglobinopathies, pregnancy, and uremia. So keep that in mind when you are interpreting hemoglobin A1C. We are going to go in detail pathophysiology that will open up how to interpret and how to make the diagnosis and how aggressive you should be in treating. US Preventive Services Task Force says the screening should be done every 3 years in adults aged 35 to 70 who have overweight or obesity. ADA, which is American Diabetic Association, their recommendation is everyone after 35 years, irrespective of the risk factors, needs to be screened every 3 years for prediabetes. Both of them recommend fasting plasma glucose, hemoglobin A1C, or 2-hour postprandial glucose. These are the 3 organizations come up with their own criteria. As you can see, International Expert Committee released their recommendations in 2009. It's purely based on hemoglobin A1C. World Health Organization published in 2006, a little different from American Diabetic Association based on fasting plasma glucose and 2-hour postprandial glucose. American Diabetic Association, this recent one, 2023, fasting plasma glucose reaches 100 and 125, or 2-hour postprandial 140 to 199, or hemoglobin A1C 5.7 to 6.4 constitutes the diagnosis of prediabetes. But none of them are 100% sensitive or specific for prediabetes. As you can see, the fasting blood glucose identified almost 30%, hemoglobin A1C close to 20%, and 2-hour postprandial 13%. Let's look at the pathophysiology of prediabetes. In prediabetes who have impaired fasting glucose tend to have higher or inappropriate endogenous glucose production because of hepatic insulin resistance, reduced hepatic glucose clearance, lower ability of the glucose to stimulate its own uptake and suppress its own production. All these patients with impaired fasting glucose also have impaired beta cell function. It is not simply insulin resistance. We are going to see that one in a little bit detail. Impaired glucose tolerance is predominantly characterized by skeletal muscle resistance, that means delayed glucose uptake, and beta cell dysfunction. With near maximal insulin resistant beta cell function losses 80% or greater in impaired glucose intolerance. So the beta cell dysfunction always associated with impaired glucose intolerance, and most of the time at least. Obesity is the most important factor or important association with prediabetes. This is the important point, the first point. Once a prediabetes develops, the glucose homeostasis is already strongly but partly still reversibly dysregulated. So dysregulation is already there when you make the diagnosis of prediabetes. The prediabetes in the context of overweight and obesity in most cases associated with increased energy intake, which can cause ectopic lipid storage in visceral adipose tissue and other organs. Among the fatty acids, diacylglycerol and ceramides leads to hepatic insulin resistance. When the liver fat content is above 1.85%, it's associated with hepatic insulin resistance. So that is the best way to check, or the easy way to do is impaired fasting plasma glucose. So prediabetes with obesity often associated with visceral obesity, metabolic dysfunction associated steatotic liver disease, insulin resistance, and relative insulin secretion failure. In prediabetes with the normal weight, they will have relative beta cell dysfunction. The fasting plasma glucose primarily determined by hepatic glucose production, further adapted by glucagon secretion. In other words, impaired fasting plasma glucose tells you there is a hepatic insulin resistance or hepatic insulin insensitivity. The postprandial state, the glucose is absorbed and insulin levels are high, both to suppress the hepatic glucose production. And also, the glucose uptake by the skeletal muscle causes glucose disposal. The postprandial state, the glucose disappearance or utilization is because of sensitivity of insulin in the skeletal muscle. So skeletal muscle insulin resistance is shown as impaired glucose tolerance. Of late, the 1 hour plasma glucose seems to precede impaired glucose tolerance, so that can be used as an early marker instead of 2 hour postprandial glucose intolerance. The concept of impaired glucose regulation. Changes in glucose homeostasis are continuum, probably starting years before prediabetes is diagnosed. This is an important point. When you make the diagnosis of prediabetes, there is already existing change in glucose homeostasis. There is no reason to believe it is pre-diabetes. There is a impairment has been going on for quite a few years. The beta cell dysfunction develops even before plasma glucose level rose into pre-diabetic range. So these two important points needs to be kept in mind when you determine whether to treat them or not. The people who progressed from normal glucose level to prediabetes have lower insulin sensitivity, normal glucose regulation, compared with the non-progressors. The steeper decrease of insulin sensitivity happens over the years. So even when the glucose is normal, the impairment of glucose dysregulations happening over the years before it manifests as hyperglycemia or impaired fasting plasma glucose. 5 years before the progression to impaired fasting glucose, the beta cell function was already significantly impaired in normal glycemic individuals. So having normal glycemia not right away exclude the possibility of development of prediabetes. The steady decline in hepatic but not muscle insulin insensitivity causes development of prediabetes. The pre-diabetic state, IFG, which is impaired fasting glucose, appears to be caused by low baseline beta cell function in combination with progressive decline in hepatic insulin sensitivity. When the transition happened from normal glucose tolerance to pre-diabetes to type 2 diabetes, the peripheral insulin resistance can first be compensated by increased insulin secretion by pancreatic beta cells. When the pre-diabetes occurs, the beta cells reach a plateau of their insulin secretions. That means it cannot secrete any further and fail to lower the plasma glucose into the normal range. They have impairments in early and late phases of insulin secretion, as well as glucagon suppression by glucose stimuli. The impaired fasting glucose happens 5 years prior to the development of impaired glucose tolerance. Very important point. Impaired fasting glucose 5 years before the beta cell function happens, beta cell dysfunction happens. Here, before the impaired glucose tolerance, 5 years before the impaired fasting glucose happens. The progressive reduction in beta cell function over time, therefore secondary to insulin resistance observed at baseline. Taken together, both IFG and IGT are conditions with impaired insulin sensitivity. Impaired fasting glucose means there is impairment in hepatic insulin sensitivity. Impaired glucose tolerance means there is low whole body insulin sensitivity. It is the further down in the route. As you can see here, there are three important things they correlate with: impaired fasting glucose, impaired glucose tolerance, and the combination of both. So insulin sensitivity is low when there is impaired fasting glucose. But most of the time when we make the diagnosis, they are already impaired fasting glucose and impaired glucose tolerance. That means insulin sensitivity is very low when compared to other two independent variables. Insulin secretion is pretty good comparatively when there is impaired fasting glucose, when compared to impaired glucose tolerance or a combination of both. Beta cell function is dramatically decreased when you have impaired fasting glucose and impaired glucose tolerance. Keep this one. So when you have both impaired fasting glucose and impaired glucose tolerance, you already have sensitivity is very low and insulin secretion is very low and the beta cell function is very much affected. Then Durbingen in Germany, they came up with clusters of people at risk for diabetes. The pre-diabetes has been linked to coronary artery disease, chronic kidney disease, and all-cause mortality. I want to show you this one. It is more of academic value than clinical value. Clinical value is impaired fasting glucose, impaired glucose tolerance, and hemoglobin A1C. There are 6 clusters they came up with among excessively based on the bodily habitus. The cluster 1, 2, and 4 indicative of low risk for diabetes. Cluster 3, 5, and 6 indicative of high risk of diabetes and high risk of mortality. Let's say cluster 1. These individuals are overweight, low genetic risk, meaning the family history is not that strong. They have low risk for diabetes. Cluster 2, they have normal weight, low liver fat, very low risk for diabetes. Cluster 4, these individuals obese, relatively low liver fat. The liver fat is very important. It gives the hepatic insulin insensitivity. These individuals also low risk for diabetes. Look at cluster 3, low insulin secretion, high genetic risk, high risk for diabetes, and high risk for chronic kidney disease. Cluster 5, obese, very high liver fat, insulin resistant, high risk for diabetes, chronic kidney disease, and higher mortality. Cluster 6, obese, high visceral fat, high renal sinus fat, high risk for chronic kidney disease, high mortality, and moderate risk for diabetes. The pre-diabetes also seen, high among certain racial groups than others. In white populations, mostly the workers done in Baltimore area, United States, 6.2% have pre-diabetes. In Pima Indians, the numbers are high, 7.8. In African American with genetic predisposition, 11% have pre-diabetes. What are the risk factors for pre-diabetes? Overweight or obesity, older age, physical inactivity, unhealthy diet, genetic predisposition. When you say older age, it's not necessarily 65 plus. Anything above 35, American Diabetic Association consider as old enough to be screened for pre-diabetes. US survey shows the prevalence of pre-diabetes is 38%. International Diabetes Federation, their prevalence is 10.2% because their criteria is more lenient than American Diabetic Association guidelines. Complications in persons with pre-diabetes. The annual rates of progression from pre-diabetes to diabetes is 5.8 to 18.3%. Any given individuals, they continue to progress towards type 2 diabetes unless otherwise you take care of them to reverse pre-diabetes to normal or mitigate the progression. The age of pre-diabetes onset influences the rate of progression. For example, if the pre-diabetes happens after the age of 60, lower the rate of progression. But if it happens early on, then the progression is faster. So there is no wonder American Diabetic Association asked the screening test to be started at the age of 35. There are no ethnic or racial difference for the progression to diabetes. Pre-diabetes have more cardiovascular disease risk factors than people without pre-diabetes. It is associated with more cardiovascular events, high mortality risk among individuals with pre-diabetes, impaired fasting glucose, impaired glucose tolerance, and hemoglobin A1C based on pre-diabetes. It is also associated with higher rates of hospitalization. Even in the absence of progression from pre-diabetes to type 2 diabetes, the pre-diabetes alone associated with 10% increase in retinopathy, 7.5 to 16% increase in neuropathy, 10% nephropathy. You don't have to even progress to type 2 diabetes. So pre-diabetes alone is not safe. It has microvascular and macrovascular complication. In addition, there is a high frequency of impaired cognition. There is a concept of spontaneous remission of pre-diabetes. I want to caution you because most of the data is coming from short time frame. Even in that article, if you wait long enough, most of the pre-diabetes becomes diabetes to the range of 96 to 99%. So I do not bank on spontaneous resolution of pre-diabetes. But I have to tell you what is available in the literature. The resolution of pre-diabetes occurred in 33 to 59% of individuals within 1 to 5 years of follow-up. 70 to 42%, 6 to 11 years of follow-up. The rates of resolution decreased with the longer follow-up. Longer you live, invariably pre-diabetes move on to type 2 diabetes. Then how to treat? Intensive lifestyle modification is the number one go-to to treat pre-diabetes. One, diet. Second, exercise. These two are very important because they are well tolerated. There are no side effects. So one should resort to balanced diet. The diet rich in whole grains, fruits, vegetables, lean proteins, and healthy fats. Reduce sugar and refined carbs. Limit intake of sugary beverages, sweets, and refined carbohydrates. Portion control. Be mindful of portion sizes to avoid overeating. You don't have to completely eat the plate. Fiber intake. Increase dietary fiber, which helps regulate blood sugar levels. Healthy fats. Incorporate sources of healthy fats such as nuts, seeds, avocados, and olive oil. Regular exercise is very important. Aim for at least 150 minutes of moderate intensity aerobic exercise per week, such as brisk walking, cycling, or swimming. Strength training, including resistance training exercises at least twice a week to build muscle mass and improve insulin sensitivity. An impaired glucose tolerance is because of impaired insulin sensitivity at the skeletal muscle level. So keep that in mind. Incorporate more physical activity into daily routines, such as taking the stairs, walking during breaks, or gardening. Aim for modest weight loss of 5 to 7% of the body weight if overweight or obese. This can significantly reduce the risk of developing diabetes. Sustainable habits are very important. Focus on long-term sustainable habits rather than quick fixes. How does weight loss and glycemic goals in the prevention of type 2 diabetes? When you have a weight loss, you decrease body weight, decrease the liver fat, decrease the visceral fat. It increases beta cell function and increases insulin sensitivity. Especially when you do weight loss, diet, and exercise, most of the time you can revert from pre-diabetes to normal glucose regulation. In addition, there are other things needed to be done, like stress management. Practice stress-reducing techniques such as mindfulness, meditation, yoga, or deep breathing exercises. Ensure adequate and quality sleep, aiming for 7 to 9 hours per night. Poor sleep can negatively affect blood sugar levels and insulin sensitivity. Avoid smoking, as it can increase the risk of diabetes and other health complications. Regular monitoring is necessary like any other disease. Regularly monitor blood glucose levels to track progress and to make necessary adjustments. Regular visits to healthcare providers for monitoring and guidance. Participate in diabetic prevention programs that offer education and support. Join support groups or communities for motivation and shared experiences. In most randomized controlled trials, the effects of lifestyle modification were primarily mediated by weight loss. The effects of lifestyle modification and diabetes incidence persisted after the discontinuation of the intervention. So lifestyle modification is the go-to and reach the goal of 5 to 7% weight loss by doing a lifestyle modification. But there is a caveat to that one. The lifestyle modification definitely improved cardiovascular risk factors like systemic blood pressure, LDL levels, and triglyceride levels. But it did not significantly reduce nephropathy, retinopathy, and neuropathy. Subclinical atherosclerosis that's determined by coronary artery calcium level has been found 75% lifestyle group versus 84% in plasma group. It's reduced, but it has not gone away. So keep that in mind. Persistent pre-diabetes who do not progress to diabetes may still face increased risk of complications. It is if you need to take one important message from this topic is the persistent pre-diabetes, it's not the safe area. By being pre-diabetes, it increases the risk of complications, all microvascular and macrovascular. Drug therapies. Compared with placebo, metformin reduced the incidence of diabetes among people with pre-diabetes. Metformin, along with lifestyle modification, causes pre-diabetes remission. In women with history of gestational diabetes, metformin with intensive lifestyle modification prevented progression from pre-diabetes to diabetes. Present ADA recommends metformin for specific group of patients. BMI greater than 35, age less than 60 years, women with history of gestational diabetes, those with higher fasting plasma glucose, like more than 110 or higher hemoglobin A1C. One should remember when you're prescribing metformin, they need to be monitored for vitamin B12 deficiency. There are multiple studies that have been done with the diet and exercise and different medications, how they affect pre-diabetes. I want to show you a few. IDDP1, Indian Diabetes Disease Prevention. In that one, they checked lifestyle modification and metformin on lifestyle modification alone. As you can see, diet and exercise alone decrease pre-diabetes 28.5%, metformin 26.4%, diet and exercise 28.2%. The conclusion is lifestyle modification alone is better than medication. That is the conclusion from IDDP1, but it was done early 2000s. IDDP2, they use pioglitazone and lifestyle modification. They're 28% through pioglitazone. And they found there is no decrease in the pre-diabetes by adding another medication. So IDDP1 and IDDP2 concludes lifestyle modification alone is good enough for pre-diabetes. But stay with me, that's not true. There are other 3 studies I wanted to show you. Rosiglitazone decreased insulin by 62%, pioglitazone 72%, and the Navigator study valsartan 14%, and there is nothing with netaglenide. This is the one published in 2023. They compare lifestyle modification versus metformin plus lifestyle intervention. This is a well-done study. They found metformin plus lifestyle intervention group further reduces the incidence of conversion from pre-diabetes to diabetes. So at this point, my recommendation is lifestyle modification plus medications. Could be metformin and also other medications, which I'm going to talk about briefly. You can see the lifestyle modification definitely decreases the incidence of conversion from pre-diabetes to type 2 diabetes, but when you combine with metformin, it further decreases. So there is no reason not to use metformin or pharmacotherapy along with the lifestyle modification. There are other medications that have been evaluated, has been shown positive effects. Iosolidones, they are insulin sensitizers, alpha glucosidase inhibitors, sodium glucose co-transmitters, and weight loss medications like orlistat, phentermine, naltrexone, bupropion, and recently GLP-1 receptor agonists, dual glucose dependent insulinotropic polypeptide and GLP-1 receptor agonists, and renin-angiotensin aldosterone system blockade, vitamin D, and finally testosterone. There are no documented evidence giving testosterone improves or prevents conversion from pre-diabetes to diabetes, but it has been shown that testosterone levels are lower in obese individuals. There is a nice mini review in Frontiers in Endocrinology 2023. It goes through all this. How to approach. This is based on the ADA guidelines. That has changed in the last 2 years. But anyway, I have to show you what the ADA suggests. The major risk factors for pre-diabetes is family history of diabetes, older age, overweight or having obesity, physical inactivity, and history of gestational diabetes mellitus. What do you screen for? Fasting plasma glucose. According to ADA, American Diabetic Association, 100 to 125, 2-hour plasma glucose 140 to 199, hemoglobin A1C 5.7 to 6.4. When to use metformin therapy? According to ADA, age has to be less than 60, BMI more than 35, history of gestational diabetes, and fasting plasma glucose more than 110, hemoglobin A1C more than 6. And the patient preference. Patient can choose to use metformin even when the numbers are not as indicated by ADA. So even though lifestyle intervention is easy, but having a therapy team allows the person to be consistent. Consistency is very important in lifestyle modification. It's not once in a while, it has to be everyday thing. Dietary modification. Decrease caloric intake by 700 kcal. Target saturated fats and simple sugars. Physical activity, more than 30 minutes per day, at least 5 days a week. Self-monitoring. Record food types, portions, calories, minutes of activity, steps taken each day. The self-monitoring usually works much better if the individual and the practitioner understand the gravity of the situation. If you consider prediabetes as a pre-disease, then you don't pay that much of attention. But if you understand prediabetes itself is a continuum of impaired glucose homeostasis, then you'll pay attention to it. That is the most important point I wanted to bring across. Weight loss. The goals are individualized. Typically, more than 7% of body weight of overweight reverses most or prevents prediabetes to type 2 diabetes conversion. When you're a smoker, start smoking. If you don't stop. Improve sleep hygiene and stress reduction. Well, the debate is whether to treat prediabetes or not. There are a couple of groups. Well, I wanted to show you two latest one. The one editorial came up in Lancet Diabetic Endocrinology in 2023. According to that one, never too early to intervene. I put it in the green circle highlight because I'm in favor of that one. There is another group just published a month ago in Journal of Association of Physicians of India by Rajesh Agarwal, prediabetes to be treated or not. According to him, only when there is risk factors, use pharmacotherapy, otherwise lifestyle modification alone is enough. In my opinion, prediabetes per se, even when there is a impaired fasting glucose, that means there is impairment of glucose homeostasis happening at least for previous 5 years. So at that point, waiting to treat prediabetes is not a great idea. In conclusions, prediabetes is a toxic cardiometabolic state associated with increased microvascular and macrovascular complications. Diagnosing prediabetes early and treat them appropriately will stop the progression to frank diabetes. It also reduces the complications arising from it. So clinicians should diagnose early and treat prediabetes. Lifestyle modification with medication helps to treat prediabetes much better than lifestyle modification alone. This concludes the talk on prediabetes.